Activate YouTube. It will take a moment, ma'am, around 30 to 40 seconds.
Yes, no problem. We have 1 minute. Yeah, it's 8 o'clock.
Sir, we are live now.
Thank you. So it gives me great joy in starting our webinar and our talks on all about biometry. We have a very exciting session planned today with very good speakers from across Karnataka and from other parts of India as well. So I'd like to start by introducing our panelists, but before that, a big thanks to Karnataka Ophthalmic Society for this initiative and also the governing council and scientific society members and panel. So our panelists include Professor Dr. Mahesh Babu, who is a professor and HOD at Department of Ophthalmology, and he has numerous publications and is also very active academically and in our scientific circuit. We have Dr. Dishita Rathod, who is a premium cataract and refractive surgeon from Narayan Netralaya, Indranagar, and she is also a scientific committee member in KOS. Dr. Rajgopal Kunatur is a pediatric ophthalmology specialist and he has a fellowship from Arvind Eye Hospital. And we're looking forward to your insights in pediatric biometry as well. Our first speaker for the day is Dr. Naveen Gopal. Dr. Naveen Gopal is a senior phaco and refractive surgeon and is the founder and MD of Gopala Netralaya, Bangalore, and has 10 years of experience in private practice. So Dr. Naveen Gopal, over to you. We're looking forward to listening to your insights about perfecting and making the best of immersion biometry.
Thank you. Thank you, Dr. Soumya. Thanks, KOS and Microvision for this wonderful session. Let me start my slide share.
Activate YouTube.
Yes. Shall I start? Am I audible?
Yes, please.
Slides are seen?
Slides are visible. You're good to go.
Fine. Yes. Thank you. Thank you, Dr. Soumya. I would like to thank Dr. Nanaya and Dr. Shivyogi Kuskur for inviting this session, making the wonderful opportunity for going back to our basics, learning the basics. See, for you to sustain your private practice, you need to get your basics right. First basics is getting your IOL calculation right. However good surgeon you are, however good OT you have, however good machine you have, if you can't get your axial length right, you will end up with a patient, unhappy patient throughout your life. Because it's your private practice, you will not go anywhere, and your patient is behind you like Vikram Mehta. So let us discuss today how to get our axial length right. Today I'll be discussing about immersion biometry. The biometry, as you know, it involves both keratometry, getting a K1, K2 right, which will be discussed by other consultants. I'll be discussing about immersion biometry. Two types of biometry we use in our practice. Ultrasound is called A-scan and optical, which uses infrared. I'll be touching upon the theory. I know it seems a little boring to you. I would like to be a more practical person, but as the moderator reminded me, we should had certain slides of basics as well. So I will touch upon the basics as well. One, it's A-scan biometry is nothing but one-dimensional ultrasound amplitude modulation scan, commonly used to determine the axial length. It usually utilizes 10 to 12 millihertz of frequency. It's based on the principle of calculating the time required for the sound to go across the eye using the ultrasound transducer, and it converts the linear value through velocity formula, that is velocity into time. 1 second, let me, yes. So what does it do? A thin parallel sound beam is emitted in the probe with echo, which bounces back to the interfaces, and these high peaks are recorded onto the machine. An interface is nothing but a junction between two media of different densities and velocities as shown in the spike or oscilloscope on the printout, what you get. Basically, what it shows is anterior and posterior spikes of the cornea and anterior and posterior surface of the lens, retina on the posterior side, sclera and the retroorbital fat. Sorry. The greater the difference at each interface, the stronger the echo will be. And the error of even a millimeter in your axial length measurement will lead to around 2.5 to 3 diopters of postoperative refractive surprise. This is the reason we need to get this right. This is how a scan looks like. And the difference in axial length measurement between the two eyes should not be more than 1 diopter or 0.3 millimeter in the axial length. This is how the normal applanation A-scan printout looks like. As you can see, there are no anterior and posterior spikes on the cornea. These two spikes are for the lens, anterior and posterior. This is for the retina, sclera, and the retroorbital fat. Here, immediately in the immersion, this is what we are speaking about. Here you can see an immediate difference. There is one more big spike. This is the probe what you have placed anterior to the cornea using a coupling agent. This is the extra spike what you get in the immersion method. And also you can see the spikes are higher. And as you can see the corneal spikes, you can see two distinct spikes between the anterior and the posterior surface. And the spikes for the lens also is more distinct in the immersion method. And the retina and sclera is as is shown in the picture. Two different types of A-scan we do. One is applanation and immersion. I'm going in detail about the immersion today. In this technique, what we do is we use a coupling fluid rather than the ultrasound directly touching onto the anterior surface of the cornea. A small scleral shell of 20 millimeters is placed on the between the eyelids, filling it with coupling fluid. A probe is immersed onto the fluid, which excludes the compression of the cornea and hence avoids any errors in the axial length measurements. Sound travels better in fluid. Always remember this. Sound travels always better in the fluid. So it is better with the immersion than the applanation if you get the technique right. These are the various shells used. We use Pager's shell or other shells available in the market as Osine or Hansen shells, which is usually of 20 millimeters, which fits most of the eyes. Bigger eyes like myopic eyes, you might need a bigger shell. Be very careful with the shells. It comes along with the machine. Don't think it is cheap. It is very expensive. It is around 30 to 50K. So place it in a safe position. Always put it in a plastic box and keep it aside. The coupling fluid, you can either use methyl cellulose theoretically, but practically what we use is saline or RL or BSS, whatever is left in the surgical OT. That is what is practically used. Coming to the technique, examination can be performed theoretically in semi-reclined position also, but supine position is always preferred. After applying topical anesthesia in the eye, a scleral shell, a Prager shell, or Osine, whatever you prefer, is placed between the eyelids and filled 3/4 with the coupling fluid through a small tube at the side till the tip of the probe is well submerged. Then you start a scan. Here I would like to add my practical point. Instead of pushing the fluid through this tube, what I do is I take out the tube itself. The problem with the tube is when you push the fluid into the small tube, what happens is air gets mixed up in the fluid and small bubble tends to get accumulated in front of the probe and in between the cornea, which can give rise to wrong readings. So I will demonstrate it practically at the end of the session. You can take out the tube. It is just a screw, it comes out. Use a 10 cc syringe with a long needle. What I prefer to use is what you get with the IVTA set. You get a big needle. That big needle, you will get very less bubbles. Once the ultra beam is switched on, the patient will you need to tell the patient to aim at the target, which is it comes as a red light in the middle of the probe. So once the patient is fixated, you start your measurements. These are the various shells available, and this is the correct position what we need to see. And as you can see, this is the correct spikes what you should see in the immersion method. As I've already discussed, two different spikes for the cornea. One spike here, which is invisible here. Anyway, two different spikes for the lens, and no spikes in between. This is important. And a good spike and the retroorbital spike. And ST, something called ST, which should not be more than 0.2. And cornea, as I already mentioned earlier, there is a separate spike in the immersion. And very nicely seen in the immersion method. Retinal schools are also in the please make sure your bio onto the immersion method. Sorry, I got disconnected, right? Where did I stop? Hello?
You can continue from that slide.
Which slide? Where did I stop?
No, you
This
were.
slide, huh?
We just lost you for a couple of seconds.
This slide? This slide or this slide?
No,
You'll
sir,
have
you
to
have to
you'll have
again
to share your
reshare.
slide.
You have to reshare, sir. Sharing you have to do again. Slide share. Yeah.
Sorry, yes, I'll come back. Sorry about that. I don't know what happened.
Nothing, sir. It is due to internet, sir. Nothing else. Yeah.
Yes, I will reshare. I'll go to my Zoom. And where is it? Oh, completely come off the
You
thing.
can go
How
back
do
to
I?
slide share.
Should I log in
Go
again?
back to slide share.
Yes.
You can
yes.
go to the
Okay.
one where you are interpreting the immersion
Yes.
A-scan spikes with the
Visible,
cornea.
right? Is this the one?
Maybe the
Yes.
previous slide?
Yes, I will go back now. Yes. This one, right? Yeah. Sorry about that. Some internet connection, I think. Yeah. This is the spikes you need to get. Am I audible now? Hello?
Yes, you're audible. You're audible.
Yes. Shall I continue? Slides are visible?
Please continue.
Thank you.
Please continue.
Sorry for that. Yeah. See, yes. You get 5 to 10 readings according to whatever machine you are using. So the axial length should not be too. You need to get within 0.12 millimeters of the range. You should not get too much varied readings of the 10 readings what you get. Standard deviation should be, in other words, not more than 0.2. Your ACD should be consistent in all the readings. And your lens thickness also should be consistent. Lens thickness is other important part here, wherein Barrett's takes into account. So you need to be careful about the lens thickness also. As I've already told, you get good spikes, corneal spikes, the lens spikes, and the scleral and the retina and the scleral spikes. Make sure you are in the, don't put it in the applanation and do immersion mode. You'll get you're in the immersion mode while you're doing immersion. That is very, very important. Seems like a stupid solution, but it has happened to me a lot. This is how if faking spike this is how if I click, this scan should look like this is the immersion method. So one big spike you get at the probe, two good corneal spikes, no spikes in between. This is the example of the poor quality spikes. As you can see, the posterior spikes are very little, two small spikes in between, and there is very little this
Dr. Naveen, I think your internet is poor again.
my should be your institution.
Hello?
Yeah, actually, sir, yeah, slides are visible, but your internet is fluctuating. That's why your sound is fluctuating, sir. Hello? Hello, ma'am. Am I audible?
Yes, you
Yeah,
are audible.
yeah.
I think Dr. Naveen must have lost internet.
Yes, I think. So he
Probably
need to,
we'll move on to the next talk and we'll come back to Dr. Naveen's talk. Will that be okay?
maybe possible, ma'am. Maybe possible. Yeah,
Okay.
yeah. Let's do that again. Yes, ma'am.
Okay. Yes.
Yeah.
Thank you. Because we had a small glitch in the internet, I think we are going to move on to the next talk. So in the, so that we save time. And is my screen visible to everybody?
Very clear, ma'am. Very clear.
Yes, yeah.
Yes. Thank you. So we are in the day of refractive cataract surgery. It's not just blindness to light anymore, but good to better now. And in most cases, we're
Hello?
able to get,
Yeah, sorry.
in most cases, we're able to get fantastic outcomes. But in some cases, like extreme axial lens, they still can pose challenges and surprises to us. So the benchmark standard for refractive outcome after cataract surgery is constantly changing. In 2009, we expected that 85% of cases would be plus or minus one diopter. And within 10 years, the expectation was that 95% cases would be plus or minus one diopter. And this is gradually going up. So we are raising the bar for ourselves, and rightly so. Now, not all myopia and hypermetropia is the same. Myopia, for example, can be axial, it can be corneal due to corneal ectasia, it can be lenticular myopia, in which case it's very straightforward for us. Similarly, hypermetropia can be axial, where you have a short axial length. We can have relative anterior microphthalmos, where the axial length may be normal, but there is crowding in the anterior segment. And then we have nanophthalmos, where the entire eye is shrunken, but usually with a normal sized, so disproportionately larger lens in these patients. So how would we define extreme eyes or outlier eyes? So any eye that is less than 22 millimeters in axial length can be considered to be a short eye. And according to different definitions, nanophthalmos can be considered to be less than 20 or less than 18 millimeters. Similarly, axial lens more than 26 millimeters are considered to be long, and more than 30 millimeters are considered to be very long eyes. And this is of interest because these patients are more likely to have staphylomas. So they do pose challenges in our biometry calculations. So we do have pitfalls in these patients because we have difficulties in measuring the axial length and measuring the keratometry, and most importantly in determining the effective lens position, which becomes very important, especially in hypermetropic eyes. So now our key considerations would be getting the right biometry, getting accurate biometry, and using the right IOL formulae. And both are equally important. So the first step, of course, would be to get a good biometry, to get good readings. And the current gold standard would be optical biometry, because this has the advantage of measuring the true visual axis. Immersion, like Dr. Naveen Gopal was mentioning, if done well, it can give us good readings as well. The least preferred would be a contact biometry, because then we have issues with variable corneal compression, and they tend to be less reliable. Even in optical, we have different technologies available where OCT based devices do have the advantage of us being able to cross check the fovea and fixation. But most importantly, if you have an opportunity, it's important to compare readings between different machines. Again, measuring the keratometry is very important, especially in hypermetropic eyes. One can use total keratometry whenever available, or even otherwise, it's important to get repeatable readings in the same device. And if possible, compare keratometry with another device like a topography or tomography if possible, to make sure we're getting similar readings across all instruments. Now coming to IOL formulae. Now, we have dealt with many different formula over the years, and SRKT and Hoffa-Q have served us very well for many years, and they still do well in most normal eyes, but they can be a little challenging or little off in eyes that are in either ranges. If it's very myopic or very hypermetropic, they can give us erroneous readings. So fortunately for us, we're living in the era where we have fantastic formula available free to us. So we have formula like Barrett's Universal 2, Kane, Evo, which are partially Virgin's formula. They partly have some amount of AI with them. They take into account the posterior corneal astigmatism, the change in the refractive index in these extreme eyes. So they are quite reliable and they give much better predictability. So long eyes can give us, unexpected refractive outcomes. This is because in a long eye, the majority of the eye is dominated by the vitreous. So there is a change in refractive index in that eye, which is not accounted for in older formula. So they assume a standard refractive index. So the advantage with the newer formula is that they account for this change in segmentation in the axial length. So most studies that have been done that have accounted for and that have checked for different formula have found Barrett's Universal 2 to be quite good. And that is my go-to formula as well. We also have other formula like Kane and Olsen, which also do well. And the good thing is Barrett's and Kane are both available online, so anybody can access this. So for long eyes, it's important to use the right formula. My go-to, like I mentioned, is the Barrett's Universal 2. In case of ultra long eyes, it may be beneficial to compare different formula and make sure they're all in agreement. In very long eyes, there is a higher chance of having outliers even with these formulas. So in case there's a lot of difference, please repeat your readings. And also most important in very long eyes is to make sure we confirm foveal fixation, because these eyes quite often can have posterior staphyloma in them. So this is a case example. This is the patient with 28.27 millimeters axial length, and I have done a calculation both on Barrett's and Kane, and they're more or less in agreement. So I've gone ahead and implanted a 4 diopter lens and ended up with a spherical error of minus 0.25 diopters, which is very acceptable. Now, in case you have not used a Barrett's formula or a Kane formula before this, it's very simple. Just go to Google and type out Barrett's Universal 2 formula. It will lead to this page. You just have to click on it. It will lead to this page. Like you can see, it's extremely simple to use. You just need to enter your parameters, whatever they have asked, and click on calculate, and it will give you the required data that you need. Now, where do you think biometry is more challenging? Long or short, or are they both equally good or equally bad? Well, the answer is they are not both equal. Longer eyes are more forgiving, and in small eyes and short eyes, even a small error of 1 millimeter in an eye that is 20 millimeters long will result in a post-operative error of 3.75 diopters, which is why it's very important to get accurate readings in short eyes, not only of the axial length, but also of keratometry, lens thickness, anterior chamber depth, and white to white, because these will determine the effective lens position in these eyes. Now, the effective lens position is important because that is where the IOL will sit, and because these are short eyes, they will tend to have very high diopters requirement. So even a small change in that effective lens position will lead to a pretty unexpected or a big surprise in the final refractive outcome. Now, one thing to remember in nano-ophthalmos is it is not only a short eye, it is also a slightly different eye. They tend to have thick sclera and they have a higher risk of uveal effusion. So along with having a good biometry in nanophthalmos, it's very important to have a good surgical plan, because there are more chances of complications in nanophthalmic eye. So it's very important to be prepared for all scenarios. Now, this is another short eye, 22 millimeters axial length. Like you can see, the immersion is suggesting I go with 26.5. And let's say I go slightly myopic, I aim at some myopia. It still is very different when we do a calculation on Kane and Barrett. So these both are in agreement, like you can see. And they're suggesting I use 27.5 diopters. Now, like you can see, even with something that's borderline at 22 millimeters, there is already a 1 diopter jump with the right formula. So this is why it's very important to use the right formula in myopic and especially in hypermetropic eyes, and very important to get good readings, especially of white to white, AC depth, lens thickness, all these parameters that need to go into these formulae. If there is astigmatism, please account for it and do treat this astigmatism with toric lenses, because then it will help get a lower residual spherical error, and that will be much appreciated by the patient. So the algorithm in long eyes is to confirm foveal fixation, is to make sure you can validate with repeated readings on different instruments or repeated readings in the same instrument. It will be great if you can run Kane, Barrett's Universal 2, Hill RBF simultaneously and then compare the formula, make sure they're all in agreement. If the Barrett's and Kane and Hill RBF, they're showing different readings, then it would make sense to repeat your biometry and make sure they're all in accordance. And in very long eyes, it's very important to watch out for staphyloma and very important to confirm visual axis. In short eyes, all readings, including white to white and AC depth, are very important because these are useful in determining the correct effective lens position. And like I mentioned, even a small change in a high diopter lens will lead to a greater refractive error. And very important to remember in short eyes is that, the patient may end up with a lens requirement of 30 diopters or 35 diopters. So before posting the patient for surgery, it's important for us to confirm with the vendor that it is available, because sometimes it may take a couple of days and we don't want to post a patient without confirming the availability of the lens, because they tend to be very high powers and unusually high powers. Before taking the patient into OT, make sure patients are counseled for biometric surprises. They are not just slightly longer or shorter. They are not completely normalized. We need to watch out for fundus changes in myopic eyes and so on. Tell them they may need glasses because that's an expected outcome in some cases, although we're very good with our formula these days. If needed, please do correct toricity as well. And beware of and counsel for amblyopia. Now, many of these patients may have had poor vision right from childhood, and it's really difficult to judge amblyopia in the presence of an advanced cataract. So in these extreme eyes, always keep that in mind and counsel the patient for amblyopia as well. And my key takeaway with biometry would be to obtain data from both eyes. It's important to take multiple readings in the same instrument, and if available, it would be great if you can compare it against different equipment and check consensus amongst different formula and make sure you take out the outliers and stick with the central values. Thank you.
Dr. Soumya,
Dr. Rajgopal, do you have anything to add?
Yeah, that was a very nice presentation. Yes, that's been my experience also, that the hypermetropic eyes give more surprises than the myopic eyes. Myopia is unforgiving in another way, because usually high myopes, we don't go in for premium lenses. I don't think we get even multifocal lenses. We end up with other. So even if they're slightly myopic, they'll be happy. But yeah, you should never target high. A myope will never be happy if he becomes a hypermetrop. So I always try to target to the myopic side, so they're more comfortable. A myope to convert into hypermetrop will be very, very, very unhappy.
it's always a good idea to aim at some amount of myopia, aim at slight myopia, both for myopes and hypermetropes. Dr. Mahesh, you are, HOD, and you must be seeing a lot of these complicated outliers. And
Yes.
with the technology that is available to you, how do you make sure you're getting good readings with the immersion as well?
See, we don't have actually optical biometry since some time, but we are doing good with immersion biometry. So works pretty well as long as you do good, used good technique with experts. So if you have the basic concepts right and you have good technicians doing it, or maybe consultants or postgraduates, it is really giving good this thing outcomes. But then sometimes I feel we had this optical biometry recently, what we plan to buy, but when it is not working in, say, for example, dense cataracts, then ultimately for few patients we have to come back to immersion biometry only. So maybe we should have both, I feel. Maybe for if some you have very busy practice and all, you don't want to rely on the technicians and all, then optical biometry is very good. It is advanced, but then as a backup, you must also have this immersion biometry also. That'll help in some difficult situations, especially when there is discrepancy between optical and immersion. I would rather prefer immersion with B scan. So maybe in extreme cases, that is my take on that.
Yes, true. Dr. Naveen, we will go ahead with Dr. Deepti's talk, and then we'll come back to your talk as well. But since
Not a
you've
problem.
just almost halfway through your presentation on immersion scan, is there anything you watch out for in high
Yes,
myopes?
yes. I just have two slides. If you permit, I will finish it
Yes,
off.
yes,
I
please,
have
please.
if you don't mind. Dr.
Yes,
Deepti,
yes,
sorry,
please
huh?
carry on. Yes, no
I'll
problem.
have
No
logged in
problem.
my. Sorry. I've logged in through my the mobile now, so hopefully I'll
Okay,
not have any problems
no
now.
problem. Please go ahead.
So no, it's not
Dr.
getting shared. No, it's okay. See, what I do is always I keep two different machines, one for immersion and one for immersion and one for applanation. And both the machines are kept in my OPD. I do all the scans rather than my assistant doing the scans. Because when you do your own scans, you have to face your own post-ops. So you have that extra motivation to get the scan right. Okay. So applanation, while holding the applanation thing, that's what I wanted to demonstrate in the video. Sorry, I could not complete it. Hold it always perpendicular to your hold it always perpendicular to the probe. And while doing the immersion, use a syringe with a needle rather than pushing the saline through the tube. That is the only two things I want to say to get an accurate reading. When you have a high myop reading, please go in a dense cataract mode. This is one point I would like to add. That's all. Thank you.
Would you consider referring the patient out just for an optical biometer if in case you had a doubt with your immersion?
Yes, definitely. If I get in the two scans, if I get two varied readings, I would recommend optical biometry, which I live in Bangalore. It comes to my hospital when I ask for it. I
That's
would like to do
fantastic.
a, yes,
Yeah.
I
So I think
definitely, yeah,
that's
you're right.
another point that we can send across is that even if you don't have it and if you feel that the patient really needs it, there's no harm in asking for an
Yes,
optical biometry to be done. Even if your center, like you said, if it is available to you or to refer to another center and come back to you,
yes,
most
yes,
patients
exactly.
will accept it well. Thank
Absolutely
you,
agree
Dr.
with you.
Naveen. If you're
Thank
able
you.
to sort your internet, then we will come back to your talk again
Sure,
whenever you feel,
sure, sure.
or in the end, we will try again if you
Yeah, we'll
feel
do
that
that.
your
I don't
internet.
want to keep Dr. Deepti waiting. Let her
Yes.
continue. Thank you.
So I'm going to share Dr. Deepti's profile, um, a small introduction. I'm sorry, one second. Is my slide moving? Okay. So Dr. Deepti is a very dynamic surgeon and academician. She's had a fellowship in external diseases, cornea and external diseases from Narayan Nethralaya and from LVP as well. She's a gold medalist from MS Ramaya Medical College and has multiple awards to her credit. She's also the NABH coordinator at Kartik Nethralaya. So really many feathers in that hat. Dr. Deepti, over to you. We can't hear you. Dr. Deepti, we can't hear you.
Now?
Yes, much better, much better. Thank you.
Can the moderator allow me to share screen? I'm not able to.
Some disturbance. I think you need to change the audio. Probably use a earphone.
There seems to be a slight issue with the audio. Dr.
Yes,
Deepti?
ma'am.
Can you hear me now, Soumya?
We can,
Yes,
yeah,
perfect.
we can
Perfect,
hear
ma'am.
you.
Internet is good, but I'm not allowed to share screen. Can you just check the permissions once?
No, ma'am,
Can
it
you
is,
check?
it is, permission is there, ma'am. You can share, ma'am.
I am trying.
I think some problem with Bangalore, guys.
I'm surprised my internet is better in Coorg.
No, my internet is fantastic, but I don't know, my
Nay.
laptop is good.
Exactly. The trials it works. So, Soumya, do you want to go to the next? I don't know. It's just not allowing me to share.
Sure,
We did
we
it
can
right.
do that. Arun sir, can we move on to your talk until Dr. Deepti sorts it out?
Yeah, surely. I'm ready.
Okay. Let me just share your introduction. So Dr. Arun Samprati is familiar to most of us. He's a very senior doctor and pediatric ophthalmologist practicing since many years. He's also the former chairman of and scientific committee of KOS and BOS, and we're very glad to have you with us today, sir. So we'll move on to your talk.
So first of all, I thank Soumya and KOS for giving me this opportunity. Is my slide visible?
It's visible, sir. Yeah.
Hopefully. Thankfully, Bangalore is not earning a bad name again. So coming to the pediatric IOL biometry, so we now saw all the problems with the adult biometry, but pediatric biometry is quite different from adult because you have to select a fixed power lens for an eye which is still growing. So that complicates the problem. So what are the two things which really complicate the decision is one is difficulty in obtaining the measurement itself. The children, as you know, are very uncooperative and doing a keratometry axial length is definitely difficult. Added to that is the problem of calculations. All the formulas which are designed for the adult eyes may not work for the pediatric eyes. So the first component is difficulty in obtaining measurements, and mostly we concentrate on the corneal curvature and the axial length, and it may be very difficult to get a ACD measurement in a child. And second thing is the IOL prediction formula. As we know, all these formulas are designed with the adult eyes and the adult nomograms. So they probably will not work. And second thing is the rapidly changing refractive status of the child's eye itself. So coming to the first component, the measurements, for keratometry, we usually need a handheld keratometers. Otherwise, you will not be able to put the child in an AR case. And even examination under anesthesia may not be accurate because again, you may not be getting the case on the visual axis. And axial length measurement, again, it's the most significant error which we normally see in pediatric biometry. Almost 1 millimeter of error equals 2.5 millimeters, 2.5 diopters of error in the IOL power. And it may increase in short eyes because, as you know, child's eyes is short eye. So it may even go up to 3.75 per every millimeter error in the measurement of the axial length. So we all have to remember that the axial length in the first 6 months increases very rapidly, almost about 0.62 millimeters per month, then followed by a relatively slower infantile phase, and then followed by a slower juvenile phase. So if you can have an access to an optical biometer, and if the child is cooperative for optical biometer, this is definitely the best method of getting the axial length. But if a child is not cooperative, then the next best method is the immersion, which Dr. Naveen Gopal has highlighted very nicely. And applanation is a very, the source of error is very high with applanation. So we prefer to do an immersion. And again, doing an immersion in a child is again a challenging job. So this is the ideal A scan, which I think Dr. Naveen has already highlighted. You have to have a good anterior and posterior lens spikes, the cornea spikes, as well as the retinal spikes. So the posterior echo should be between 50 to 75% of the maximum, and retinal echo is 75% or more. So only then you will be having a good measurement. So you have to have multiple measurements to ensure that it is consistent. So this is the problems with the measurement. So next we go to the problems with the formulae. So as I said, all these formulae are done with adult eye in this thing. So the predictability of these formulae for a child eye is definitely not very accurate. But there are a lot of conflicting reports in the literature. But the commonly used formulas SRK2, SRKT, Offer Q, and Holiday 1 and 2. These are the commonly used formulas for pediatric biometry. There is another interesting pediatric IOL calculator available online, which I wanted to highlight. Basically, this is a modification of the SRK2 using the Holiday algorithm. So this gives us a very good measurement, which suppose you enter all these basic data here, the date of birth, the measured axial length, the average K, and the A constant of the IOL, and you can enter the desired age of emmetropia. So suppose if I want the emmetropia at the age of 18 years, you can enter that one. And the refraction target, if you want to have a particular, you have to leave 2 diopters of hypermetropy, you can enter that one. So here in the results, you will see, it will give the current age, like whatever is necessary for emmetropia, whatever. I'll just show in this example here. So I have fed all these data here. So emmetropic eye, suppose if you want to have an emmetropia today, immediately after the surgery, so probably you have to implant an IOL power of 35. Same thing, if emmetropia is necessary at the age of 2, probably you have to implant an age of IOL power of 29. And the same thing you can just calculate for different ages. So depending on what refraction you want to attain at present or in the future, you can enter the data here and get the power. So this is quite a useful tool for people doing pediatric cataract surgery. So once you have done the measurement and the calculation, then again you need to do IOL power selection. It's not like the adult eye where you have got the biometry, yes, you are going to implant this power. There are a lot of other factors which can influence the selection of the IOL power. So one thing is that there are 3 major approaches for the IOL power calculation. One means implantation, what power you need to implant. The first initial approach was to get an initial emmetropia, means as I said in the previous example that 35 diopter lens was necessary for emmetropia. The other approach is to have an initial high hypermetropia. Aim is when the child is 18 years, the child will become emmetropic, means the child will not have to wear glasses as an adult. And the third in-between approach is something called the initial low hypermetropia. We'll just see the advantages and disadvantages of all these 3 approaches. So what happens is when you have an initial high hypermetropia, it's definitely good because as an adult, child will not need glasses. But unfortunately, initial high hypermetropia, child has to wear glasses or contact lenses immediately after the surgery. So if the child does not wear glasses, then there is a very high risk of amblyopia because hypermetropia is a highly amblyogenic factor compared to a myopia. So that's why we should be very careful in going for this approach. So suppose if you go for the initial emmetropia, So this is a good approach because especially in unilateral cataracts, you have to have an initial emmetropia. Otherwise, managing the amblyopia becomes a major challenge. So, but however, the price we pay is when the child is older, he may have a very significant myopia, almost to the tune of 8 to 10 diopters of myopia might be there when the child is 18 years of age. So this is one thing we need to consider while going for this approach. And the in-between path is something called as the initial low hypermetropia, and most of us go for this approach. So this is balances between the high myopia in the child adulthood and managing the amblyopia at the present condition. Other factors which influence the decision is one is the age of the cataract surgery. So suppose if you are doing cataract surgery at a very young age, in the first 1 or 2 years of age, then you have to really undercorrect almost about 20% of what measurements you get. Same thing if you are doing a surgery after the age of 2 years or 6 years, then the probability of undercorrection might be much lesser. This is the current recommendation from the AAO. You will find this chart in the net. And there is another rule, the rule of 7. So here, what is calculated is, suppose if you have an age, like suppose you have a 3-year-old child, and what is the target hypermetropia you should target at? So you minus 3 from 7, that becomes 4. So 4 is the amount of residual hypermetropia you have to get. So that as a adult, the child will have very minimal refractive error. Means it will be almost an emmetropic child. And above the age of 7 years, you implant whatever power you get. So this is the rule of 7. Status of the fellow eye is also very important because especially when you're doing a monoocular cataract, a unilateral cataract, whether the other eye has a high myopia or a hypermetropia or emmetropic, so that makes a influence, that will influence your decision on what power of the lens you have to implant in this side. Visual acuity, if there is a dense amblyopia, as I said, unilateral cataract, they'll have dense amblyopia. So here we have to aim at initial emmetropia because treating amblyopia is more important than treating myopia at a later date. So we do have a lot of options for correcting the myopia at a later date. But if you don't correct the amblyopia, child will not be able to see at all. And the other thing is the expected compliance to the glasses. So I said we are aiming at an initial mild hypermetropia, but that also is amblyogenic. Even a 1 diopter of hypermetropia can cause amblyopia. So if you feel that the compliance of the child, if they are from a very rural background and if the patients are not very educated and they don't understand the seriousness of this treatment, then it is better to plan for an initial emmetropia and then go for glasses at a later date. And parental refractive error is very, very important. If one or both parents have myopia, then again you have to significantly undercorrect the power to be implanted. And the IOL power itself, suppose if the child, some child has a IOL power of 50, emmetropic IOL power of 50, you have to undercorrect more compared to a child which has an IOL power of 40 or 30. And status of we are the site of the fixation of the IOL, as we all know. If a lens is not implanted in the bag, you are implanting in the sulcus, then you have to again undercorrect. And this is the flow of events, like you do the A-scan, either optical or immersion biometry, then calculate whatever is the power necessary for achieving emmetropia and decide on the undercorrection. How much of undercorrection depends on the age, status of the fellow eye, the present visual acuity, assume compliance with the glasses and the family history of high refractive error, and accordingly you adjust the power of the lens to be implanted. So to conclude, even though IOL biometry has made vast progress in terms of the accuracy, the IOL formulas and everything, the pediatric IOL calculation still remains an enigma, and poor cooperation and changing refractive status are the main barriers in achieving an accurate biometry. Thank you.
Thank you, sir. Dr. Rajgopal, would you like to add on something?
Sir has covered it comprehensively. That's what even I do. Yeah, here the biggest problem is taking the keratometry readings. We can always carry our A-scan machine up, but doing the keratometry readings, especially in young uncooperative children, is difficult. So if we are doing good numbers, it's always better to have a handheld keratometer. And the only thing that I modify is based on the Indian studies, the undercorrection, we no longer do it only up to 7 years. Even up to 10 years of age, we are undercorrecting because unfortunately the myopia is increasing a lot. And of course, very aggressive myopia control measures, like probably, of course, we start off with atropine at the earliest stage. Even like, see, we would have given plus 2, 2.5 because we would have undercorrected and given 2, 2.5. But if it drops to 1, 1.5 also, we still consider it. Even though it's still hypermetropic, that shows that the axial length is increasing. So aggressive myopia control measures is one thing that we have to consider.
Dr. Rajagopal, do you feel atropine works in a pseudophakic eye also? Any experience with that?
No, it's not working well, sir, but yeah, I mean, I don't have studies, but as of now, there's no other option. Compared to the phakic eyes, pseudophakic, especially unilateral pseudophakics, it doesn't work well, sir.
Arun, sir, what would you what would you do? Would you consider, if it is changing too fast, would you consider something else or just wait and watch for these pediatric patients?
No, definitely we need to do some intervention because we cannot just sit and watch. Atropine, in my limited experience, is not working as well as in a phakic patient, in pseudophakic patients. Glasses is another, myopic glasses is another thing which we can consider, which probably might work better than the drops.
Dr. Bhupesh, did you want to add on something?
So I had a question. So, sir, what is your take on multifocals in age group of 10 to 12 years of age group?
Sir, actually, to be honest with you, even the multifocal in the adult itself, I'm discouraging them because of the photic phenomena. So definitely, I don't recommend multifocals in children. Probably if the refraction is stable, we can even consider an EDOF lens. Probably that might be less forgiving than the multifocal lens. But even that, I feel, is definitely not a good thing. Probably what is a better option is you just put a monofocal lens, wait for the refraction to stabilize till the age of 18 or 20. Then go for a piggyback lens. You can put a multifocal EDOF or whatever you want. That probably might be a better option than going directly with the multifocals. But toric lenses, yes, toric lenses are definitely useful in children. I have implanted a toric lens.
I also would not say multifocal lens because even especially in unilateral cataracts, the vision development wouldn't have been complete. So in multifocal, we are splitting the light. So we have to give as sharp vision as possible. 100% of the light should hit the retina. In multifocal, but 25-30% of area only will be stimulated. So putting multifocal in children, amblyopia treatment becomes very, very difficult. So I would go for a monofocal. Toric lenses in elder children is fine. See, problem what happens is in the younger children, you put a toric lens, the corneal curvature changes. Then if you want to plan a refractive surgery, the calculation becomes huge difficult. So younger children less than 10 years, I still would hesitate to put a toric lens because later in life when they turn 18 and once the refraction stabilizes, this one. But in an elder child, maybe 10 years, more than 10 years, we do not expect a huge corneal change. Then we can go for a toric. That is what is my thinking and what I follow.
Dr. Deepti, are you ready with your talk?
Yeah, yes.
Now your audio is very clear.
As Naveen said, I think Bangalore internet does something. Fine. Is it visible, sir?
Yeah.
Yes.
So I think thank you, Dr. Soumya and Chaos, for having me here. And I think it's a very nice topic, Soumya, about biometry. How much ever I think we advance in surgery, this is something that unless accurate, whatever we operate is not going to fetch us. And as Soumya told, we were discussing and we were thinking, should we do post-LASIK? And then we thought, no, post-LASIK is so common now. Any general ophthalmologist would get patients who have had LASIK because that's a very popular procedure from the last decade. And I think all of us, we operate them or no, should know what happens in post-LASIK. And at least even if we are not operating, we should not end up giving a refractive surprise to these patients. So it's very important to understand the dynamics of an altered cornea. So as we see from the last 5-6 decades, I think IOL calculation and the biometers have evolved. And the last few decades, the main evolution was what Soumya told about short and long eye, and a huge change has come in post-refractive, post-RKI, because we have been seeing a lot of these patients doing refractive surgeries for last few decades. So the newer formulas are very accurate, as when maybe even 5-6 years back. Most of us are not that apprehensive when we see post-LASIK cornea, because there are a lot of long-term results and we sort of can be on target most of the time, if not all. So a few years back, it was a very overwhelming topic, just because there's so many names which we have never learned during our period, or we have never used during our routine cataract surgeries. So I think post-LASIK calculation is hyped and seems very confusing just because of the hundreds of formulas and the evolution, which I'll take you through. But I'll just keep this presentation very practical. I think theory, we'll all get it. There are a lot of articles, but I'll just tell you what we share, how we practice, and what we follow in post-LASIK eyes. And we'll mostly speak post-myopic LASIK, because hyperopic, again, is a totally different ballgame. Now, when you speak of post-LASIK, first thing to even understand what is the right formula or calculation is to understand why a normal Barrett's or a normal SRKT, which does wonderfully in a normal cornea, does not work in these altered cornea. So there are just 3 errors that we need to understand. The most important error is the error of radius of curvature, and the second is the error of index. So these 2 are related to the corneal measurements. And the third error is the error in the formula we use. So I'll just take you a little in detail. The first radius error is a very simple logic. Now, whenever all of us are doing our ARK for our Barrett's for a regular cornea, we all know that the ARK is actually taking the measurement from somewhere around 3 to 3.2 mm. And whatever is inside, which is our main visual cornea part of the cornea, is extrapolated. That's why it's called a simulated K or a sim-K. So it's actually not the right reading, it is extrapolated. Now, this is perfectly fine in a normal virgin cornea where you have the normal shape. So even if you take the millimeter from, say, around 3 mm zone, you are getting a pretty bang on central corneal measurement. But look at the lower image where after a myopic LASIK, your cornea is very, very flat. It may be as flat as 34, 35, 36. And the periphery or the mid 3 mm zone may not be that flat. So I'll just give you a simple example on this patient who has had LASIK. So look at his sagittal curvature. I've just masked the central 3 mm, which the ARK is not measuring anyways. So if the ARK is measuring at a 3 mm zone, look at the case in that area. So it is 37 and 38, and obviously the mean you're getting is a 37.5. But if I reveal to you the central K reading, you will see it is 34.8, which is almost 3 diopter flatter. And if you go take a 37.5, you know already you're 3 diopters off and you're getting a huge refractive surprise. So this is the biggest issue when you use a regular ARK machine or an automated keto. So never use your ARK, AK or a SIM case from your topo. It doesn't mean in a pentacam the K readings are different. Even pentacam, the K1, K2 is just like your ARK. So do not take any of these SIM case from your topography or pentacam. So the second issue, what happens is the index error. Now, what is this? Now, whenever you look at a keratometry, either in your pentacam or your keratometry, it always calculates the radius of curvature and converts into a dioptric value using the simple formula, which we all know, and where N is the keratometric index. So 1.3375 is not a magical number. It is derived after a lot of thought process, and basically it considers all the 6 or 7 parameters based on which we get 1.3375, which is pretty accurate for most of our regular cornea. So an assumption that this makes is your posterior cornea is around 1.2 millimeter steeper than your anterior cornea. It's simple. Now, again, in post-LASIK, as you would see, the left eye virgin cornea, the anterior and posterior proportion is maintained. But if you see the right eye, the posterior is much, much steeper than the anterior. It is not 1.2 steeper. So this index, which is there in all our regular formulas, falls short and you get a hyperopic error. So never use the regular K reading. So third and a very interesting error that happens is the position of the lens. So if you look at the evolution of the biometers, or the IOL formula, you will see there are just 3 parameters that are required, and why we still fall short. I think most of the surgeons, this is world statistic, are somewhere around 80%, and very few surgeons reach 90% of that 0.5 diopter accuracy in a regular cataract. So the whole problem is because of the ELP. So axial length and keratometries are very accurate with today's machines, but most of the issues happen because of the ELP, which is not calculated properly by the formula. So a lot of research is happening only to find out the effective lens position. Now, to take you through how the third generation formulas calculate the ELP. So if you look at the left eye, the steeper cornea, automatically the formula is assuming that your AC depth is larger and it is suggesting a posterior ELC. Vice versa, a right eye, which is a flatter cornea, where you are assuming it is a shallow AC and your ELP is shallow. But look what happens in LASIK. You actually have a deep AC because these are larger eye. But unfortunately, because we are flattening the central cornea, the formulas are assuming that the lens is much closer because the cornea is much flatter. So we're doing exactly opposite of what should be done. And a 1 millimeter change in ELP can cause a refractive surprise of almost 1.5. So these are it. You have to understand in post-LASIK 3 simple errors that happen. And if you understand why each of these are happening, you can easily work on each of these elements to get good results in your post-LASIK. So all these 3 errors are causing an overestimation of your K readings and underestimation of ELP. And most of the time, if you use a Barrett's, you will land up anywhere between +3 to +5. You'll have a huge hyperopic surprise. So how do we avoid this? So the first 2 issues, which is mostly due to the assumptions that are made considering it's a virgin cornea, can be overcome by a lot of today's topographers and optical biometers, which also look at your posterior curvature and does very few assumptions. They're actually truly measuring your anterior and posterior curvatures. And the third error, formula error, can be overcome by using formulas which don't assume the effective lens position based on the K reading. So this is what is confusing all these names. So there are a lot of work that has happened. And I think just for historical purpose, we should know, because there's so many doctors and statisticians who have really worked on this niche subject of post-LASIK. But practically, we don't have to use any of these except for these 4-5 things. So I think over decades, we have been very fortunate to get a lot of studies which have shown us what works and what not. And we are pretty in a comfortable zone where most of our results are accurate if you follow a few of these which doctors are following worldwide. So just for completion, I would just quickly run through how these formulas work. So it's very simple. There are just 3 sets of formulas that can be used. The first set is where you just have historical data and nothing else, which I don't see an indication at all, because you have your patient and you can measure. So these were the popular types of formulas then. The second set was used for quite a few years, where you also use the old pre-LASIK data and use the present corneal measurement. And rightly, what we are using is, most of us, I think we are using the current corneal measurements, because many of these LASIK patients might not have gone LASIK with us. But if you have access to the pre-LASIK data, it always increases the accuracy. So this is clinical history method. All of these are very known formulas. You just have to run these formulas. The double K is a very interesting method where you use the pre-op K reading to find out the ELP, and then the post-op K reading for the IL power. Works very well. Even now you can use it if you have the pre and post-op. Lat-Canny was again a popular method, and Masket again. So contact lens overcorrection method is a sensible method, but it's quite cumbersome. You need to put a plain or hard lens. I think it's almost obsolete. So what works today is actually measuring your true corneal powers and using a formula which works, as simple as it is. So most popular and the gold standard today is Pentacam. We may have it, or it's very easily accessible. If you have a post-LASIK patient, you can just refer him to a Pentacam. It is a beautiful device. It's a Scheimpflug based device. And when you ask for a Pentacam, if you don't have it, this printout, which we generally get for Keratoconus or LASIK, is not of any use. You should ask for these 2 printouts, that is the TrueNet Power and the EKR. So for people who have not used Pentacam, it gives at least 20-25 types of reports. And if just send for it, what we usually give to the patient is a quad map. So these are given only if a referring doctor asks So these are the two scans that you'll have to ask for. Now, TrueNet Power is an excellent tool, and this is our go-to to find the true corneal central power. So it takes into account your anterior, posterior, and these are the refractive indexes. So what you get is a printout like this. You either can take the central TrueNet power, or what we generally take is an average of the TrueNet at the pupillary zone, which is usually 3 to 4. So most of the time we'll end up taking an average of the central 9 areas. Another useful print is the AKR, has been very popular for decades, which is how it looks. So you take the effective corneal power at this 4.5 zone and you can take the mean of it. So these are the two values which actually give you an actual K reading of the cornea. So if you have or access to an IOL master, TK is very popular these days. You can use total keratometry. Again, the IOL master takes into account the posterior cornea, so it's very accurate. If you have an op scan, it again gives you a total optical power map, or if you have a placido topography, you get values like the ACCP. So there are a lot of devices, even optical devices and topographies, which can give you any of these 5. So just to summarize, never use a SIMK from your K reading. You can use your TrueNet power from your Pentacam. You can use a TK or a total keratometry from IOL master. You can use total corneal power, which comes to a lot of our topographies. And lastly, you can use the EKR, which has been very popular from the Pentacam. So these actually give us the true corneal power. Now, once you have the true corneal power, what formula do you use? So there are, as I told you, the position of the lens or the ELP is what is very confusing, and most of the formulas are here. So just to take you through the evolution of formula, the first generation formula, as soon as you put it, it would calculate the effective lens position standardly 4 millimeter behind the lens. Is it an 18 mm lens eye or a 26 mm eye? Didn't bother. It just would put it 4 to 6 mm behind the cornea. The second generation formula started changing the EPL based on only the axis length. Again, it is very erroneous because you can have a asymmetry between your anterior posterior. And the third generation formula, which again don't work, bases your ELP on your corneal curvature. So you have the SRKT, which truly fails in your post-LASIK. So what you should be using are the generation formulas where you also look at your white to white, AC depth, lens thickness, and CCT, which gives us a much better ELP. So Haig's L is a very popular formula for post-LASIK. It is incorporated. You can get it free from the ASCRS online calculator, or if you have an IOL Master 700, you automatically get it included. So this is an excellent formula and a go-to, and all the results on online or you see show this is a good formula. And I think Barrett's TrueK has changed a lot of things, and again, an excellent formula purely for your post-LASIK patients. So it is again freely available. You just have to go to the website written here, and it asks for it's very similar to your regular Barrett's, just have to enter it. It has a separate mode for toric and a spherical IOL, and it has its terms and conditions. So once you enter it, it automatically calculates your TrueK. So it's very important, don't get confused, is not to enter the TrueK because Barrett's TrueK already has a compensation. So when you're using Barrett's TrueK, you should enter your SIMK or your regular keratometry reading and not the TrueK from the Pentacam. The name is a little misleading. So once you enter it, the formula automatically gives a TrueK value, and the results here are pretty accurate. And I think what really, again, was a game changer is this free ASCRS tool, which is a very popular tool for post-LASIK. So this has a huge database. It has both myopic, hyperopic, and you'll be surprised how many parameters it asks for. So whatever device you have, a Galileo, Pentacam, or Tomy, or a topographer, you can input only that many devices, and you'll have to just put your regular what you put in Barrett's. And this beautiful compilation has almost 14 formulas incorporated. So as soon as you put in your parameters from whatever machines you have, it's going to give you an option to calculate. And once you calculate, this is how your printout looks. So few tips here is more number of parameters you input, more will be your accuracy. So even if you have a little information of the pre-op, K reading, IOL, refractive error, it's always nice to put it. But if here I've just put a Pentacam, and it's with the Pentacam and axial length, it's given me around 5 parameters or 5 formula. So end of it, it also gives you what is the minimum and what is the maximum. So one mantra, which I will anyway show you, the last two things are very exciting. I think ray tracing in biometry is coming a big way, where you do not do any assumptions. There's absolutely no assumption of a ELP or a posterior, because your ray tracing device is actually calculating all the touch points from the lens to the retina. I think this is something which is going to be a game changer. And I think Aura, all of us have heard, there are a few installations in India as well, which is an intraoperative refraction. And this will be great for our LASIK patients, post-LASIK patients, where on the table it performs a refraction and you can have your entire library of lenses there and you can put it. Now, coming practically, what has actually worked for us? So I think one important thing is always analyze. We analyze every cataract, not only a complicated. So this is a complex looking Excel, but it's very important to look at your results. You may be multiple surgeons, you may have different SIAs. So even if before you enter into post-LASIK calculation, always look at your SIA and what is the results in your hand. Once you know this, at least perform 5 cases, or even if not lesser cases, to see what formula works. So for us, what has always worked is TrueNet power and a holiday EKR 4.5. We enter that in the regular Barrett's 2, not in the Barrett's 2K. And we also do the ASCARS calculation, ASCRS. So we do all of this for all post-LASIK, and you also should have your own customized chart. This is our post-LASIK chart, where we're entering K reading from at least 2 or more devices. So we have the AL scan, which is an optical biometer, pentacam, topography, and ARKV. So we put in K readings for 4-5 of our machines. And this is our go-to, as I said, TrueNet power and EKR. Then we run it with so many formulas here. So the mantra, if you're really confused in a post-LASIK, which will work most of the time, is whichever machine of yours is giving the flattest K reading. So here, if you see my 39.60 is flattest, that is what to be considered. And whichever formula is giving you the highest power, so that is to be considered. So this is just a thumb rule. It's not that it has to be bang accurate, but this is the thumb rule for any of your post-LASIK. Choose the flattest K reading and the highest powered lens. And if you see here, we targeted, we put a +20, our target was -0.25, and we achieved a 0.5 myopic. This was a monofocal lens. So always customize, look at your results. Something worked for us may not work for the other person. So you will have to try it on your patients and then get a final, and you will eventually reach a comfortable zone. So this is the most important. Use your flattest keratometry and your highest power, and it's always better to err on the myopic side. So I think IOL again is a different ball game. So always look at your topography. So this is a decentered ablation. So obviously a monofocal will do well. This is quite a central ablation, not much superior inferior asymmetry. So they do well with EDOFs or even multifocal. And this patient again is grossly decentered aberration and nothing other than a monofocal. So what would be my ideal scenario? One patient of ours who underwent LASIK with 2012, and we did a surface ablation of 2.5, and she just reached us last year for LASIK. So for a cataract surgery for PSC. So we had her entire pre-op data, entire post-op data. It was a jiffy for us to run all these calculators. And we implanted a multifocal because she was the ideal patient. She had a smooth cornea. We had very accurate pre and post-op. And this was her results. So multifocal, yes, for a niche group of post-LASIK patients is a great option. But not all patients can be this good. It's always better to safeguard yourself with a good informed consent. Tell them about refractive surprise. High myopic have their own issues with the macula and the periphery. Higher order aberrations will be there because they are not virgin corneas. So I think take home message is, I think we should all be aware of this because we will be dealing with these patients more now. We are having SMILE patients coming for cataract surgery, and none of us really know how exactly the post-myopic LASIK behaves with them. So always tell your patients, give your LASIK patients, it starts from here, a good report of the pre-LASIK parameters, and always tell them when you have cataract, this may be useful. So we have been doing this from the time we start LASIK. So all our patients have their pre-LASIK data. Always understand the optics. And this is a very evolving field because AI coming into it, so always stay updated. There are a lot of formulas which keep coming in, and what works for one may not work for the other. So you will have to customize based on the equipment that you have. And flattest K and highest IOL power is always the mantra. Lean towards a myopic error. You would not want to make them hyperopic for sure. And these are patients who really want to be glass free. That's why they first had their LASIK. So, but still keep them very practical, grounded, promise less and deliver more. And if you use most of the gadgets today, it's not very tough to get bang on results in your post LASIK eyes. Thank you so much.
Thank you, Dr. Deepti. That was really very comprehensive and very interesting. Do we have Dr. Dishita with us? Yeah. Dr. Dishita, would you like to add on something or probably
Yes, first of all, Dr. Deepti, it was a wonderful presentation. You summarized everything from the theory to all the practical aspects so well. Just one thing that I would probably want to add is taking the biometry values, training our technicians, and of course, checking it ourselves also would be very, very important, especially in the post refractive cases. And luckily, in a lot, hello? And also, luckily, in a lot of the newer machines, we have the LVC mode. So, that also is something that we need to either do it ourselves or train our technicians to keep it in mind.
Dr. Naveen, you wanted to add something?
Yes, Dr. Deep, you told you preferred a multifocal in LASIK, no? What about the higher order aberrations like Zernicase and in a post-LASIK, post-ablated stroma? Will it not affect the rings already or compromising the incoming rays by 20%? If another 80% rays are compromised with Zernicase anomaly, what about the night halos? Doesn't it become worse?
So yeah, that's a very good question, Naveen. So as I said, this is for a very small group of patients. So if you saw, she was our own patient whom we did LASIK, and her post-op case were not very bad. It was like 41, 42. It was a very low power surface ablation of 2.5. So all these certainly should be considered. Your higher order aberrations, what is your K? You would not want to do it in a very flat or a steep, but this was almost like a virgin cornea. So that's the only reason we did it. But the take-home message certainly is not that we put multifocal. So topography should be centered, and you should know your ablation zone. It should not be decentered. I think an EDOF is a good compromise. Today, a lot of us are doing EDOFs because it doesn't have the photopsia as photophobia, dysphotopsia as in multifocal. But this was a very selected patient whom we were sure of our biometry, we were sure of the calculation, and it was almost in a normal corneal parameters. But yes, all of this have to be perfectly seen before you offer multi.
Rather than EDOF,
so I think monotorics are very good. EDOF is a good option if your patient is really particular, and my multifocal is only for these niche group of patients.
Micromonovision also preferred in this patient if dominant type of and isn't it?
That will be the best option.
Yes, thank you.
Monovision with post LASIK.
Yeah. So can we move on to the next talk? I'd like to introduce Dr. Bhupesh first. Dr. Bhupesh is a senior consultant of cataract, cornea, and refractive surgery at Bharati Eye Hospital, New Delhi. He has multiple fellowships from LV Prasad Eye Institute as well as Narayan Netralaya. And his areas of interests are corneal transplant and challenging cataract surgery. And he's also academically quite active and has published many scientific articles and has been part of many instruction courses. So Dr. Bhupesh will be speaking to us on negotiating biometry challenges in keratoconic eyes. Over to you, Dr. Bhupesh.
Thank you, Dr. Soumya. I'll share my slides just a second. Yeah. Is it coming now?
Yes.
Is it visible?
Yes, it's visible.
Okay, fine. So thank you, Dr. Sommer, for this wonderful webinar on biometry. I think this is the most crucial thing if you want to get good results in cataract or any other surgeries. So I'll be speaking on biometry in keratoconus. So keratoconic corneas are not normal corneas. This is the first thing you should know. And these corneas have very high cylinders in many cases, those that induces irregular stigmatism. The cones are sometimes central, sometimes decentered cones. So to get the correct K value is very difficult in these patients. Another problem with keratoconus cataract is these patients are mostly slightly younger than the normal cataract population. Keratoconus patients develop cataract slightly early, and younger patients have more demands. They want perfect vision. So this is another issue to get a bang on good biometry to get a good outcome. So let's start the discussing the problems in biometry of keratoconus. So the main issue in keratoconus is excessive anterior corneal steepening. So this is steep anterior corneal surface becomes abnormally steep and asymmetric, and the standard keratometry measures only this surface and therefore exaggerates corneal power. The clinical relevance of this steepening is that steep anterior curvature falsely suggests a highly powerful cornea because regular biometry don't consider the posterior astigmatism, whereas there is disproportionate posterior corneal steepening also. The posterior corneal curvature increases earlier and more variably than anterior curvature. So this change is invisible to conventional keratometries. In result, the total corneal power is lower than what we measure, and it is assisted by the anterior curvature alone. So the clinical outcome of this is the post-operative hyperopic refractive surprise in all these cases if you go by the anterior biometry only. The other main challenge is a decentered cone because these patients have sometimes mid-peripheral cone, sometimes inferior cone. So it's very difficult to get the centered K values or the correct K values. And conventional biometry usually fails in getting the correct values. So if we compare the anterior and posterior curvature between normal and eclectic corneas, you can see in the first picture with the blue one, the apex of anterior curvature it matches totally with the posterior curvature, but it is not in the case of keratoconus. The anterior curvature doesn't coincide, the most steep point doesn't coincide with the posterior curvature, and this is a cause of severe problem in biometry readings, in keratometry readings. So what is the impact of this problem on corneal power? So the main issue that most formulas nowadays works on the effective lens position, and most eye formulas use corneal curvature to predict effective lens position. And with the conventional biometry, you measure the wrong corneal curvature. So again, you are going to measure the wrong ELP. And if you measure the wrong ELP, again, you are adding the additional hyperopic shift in all these cases. So the normal formula are made for the normal corneas. So you have to do something extra to get a correct value in these cases. So we compare the normal cornea with the keratoconus cornea. You can see the anterior to posterior corneal curvature ratio is usually consistent between 1.2, 1 to 1.2, with that Deepthi also told. But in keratoconus eyes, this relationship is disrupted and the posterior cornea steepens disproportionately. So the impact of biometry is that standard formulas fail and overestimation of total cornea. Coming to the ACD, ACD is also taken in consideration in many formulas. In in cornea, it is a standard ACD in all these cases, but with keratoconus eyes, it is generally deeper, 0.3 to 0.4 millimeter average in all these cases, and it disrupts the effective lens position more. Coming to the third, corneal apex. Apex is usually centered on visual apex in normal corneas, whereas it is decentered in keratoconic eyes. So the measured key values do not reflect the functional optics. If we talk about the IOL formula accuracy, in normal cornea, it is highly predictable. In keratoconic eyes, it is reduced. There is a reduced predictability and high risk of post-operative refractive error. Keratometry repeatability is highly repeatable in normal corneas because of the centered, well-centered and well-regular cornea. But in keratoconic eyes, sometimes the patient moves the your conventional keratometers take reading from the different part of the cornea, and you keep on getting different values. And all these factors together gives you a hyperopic surprise in all these cases, or good IL power calculation in these cases. So, so always, if you have a opportunity to use optical biometry, go for optical biometry, because with ultrasonic biometry, it's very difficult to put your ultrasonic biometer on the center of the cornea, because you don't know what is the center, because it's totally decentered cornea. So go for the optical biometer or than ultrasound based system. The optical biometer, the subsource OCT system, uses the low coherence interferometry to measure intraocular distances with very high precision. It measures the axial length, because the keratometry reading, you're not very sure what you're measuring. Chances of error is very high. So if you get a good axial length measurement also, then maybe you're going to get a more predictable IOL power calculation. So axial length is the most reliable biometer formula and should be always obtained using an optical biometer. So as this slide I've already discussed, I think cone and the SSOCT thing. So what I use in my practice is a pentacam in all cases of keratoconus. Don't go for the conventional one, and don't go for autorap and all these things. Best is if you have a topographer like pentacam or opscan, go for the values from these machines, because these machines are elevation based devices, and it gives a true geometric height data, and it gives the correct estimation of anti-elevation, post-elevation, and corneal thickness distribution. So if you take a K values from these devices, this will be more accurate than the conventional devices. And this is the go-to value, that is the EKR, equivalent K reading. And EKR is the average keratometry reading in a 4.5 millimeter zone. And this value is around 65% of the total corneal power within the 4.5 millimeter zone. Go for a holiday EKR report and take these values, K1 and K2 from here, and 4.5 millimeter zone EKR values also you can take as a mean K. So they are the different formulas that can be used in keratoconus patients. SRK-T formula works in all the cases. Similarly, it works well in keratoconus also. But if keratoconus is mild to moderate, so if KC is mild to moderate, you can use standard SRK-T formula and you get a good result, good outcome. But you should take all these patients for on a myopic side always at least -1 diopter of myopia, because these patients are myopic throughout their life. So you should not land up in hyperopia at any cost. So always target at least -1 diopter in mild to moderate. If the keratoconus is very severe, very advanced keratoconus, it's not a bad idea to go for 1.5 diopter to 2 diopter of myopia also. Haig's formula works very well. And most importantly, ELP is calculated from the measured anterior chamber depth, axial length, not from K values, because K is a main problematic thing to calculate in KC, so it doesn't take account the K values. So Haig's gives a good result. Again, in mild to moderate cases, the results are good. In extreme cases, you cannot guarantee the results. Barrett-Rucke is a go-to formula for any situation, whether it's post-LASIK, normal cataract, AC, or in any situation, go on a Barrett ACRS calculator, feed your values and get the good results. Do well, give good results in mild to moderate cases. Always, again, in this formula, also try to go further on the myopic side of -1 diopter. There are two new formulas, Kane KC formula and EVO formula. So these are online calculators. You can put your values and get a good value. Kane works very well. These are the theoretical optics formula that works on a regression data. And these you have to feed these parameters. And again, the caution is it's not reliable in severe cases. So again, mild to moderate cases, Kane works very well. EVO formula is emetropia verifying optical formula. You can get this formula on the online evocalculator.com. And you have to put all these values from different machines, and then you can get a good result with the Kane also. Kane and EVO perform similarly in KC cases. And again, in severe keratoconus, predictability declines. Another important factor in keratoconus cases are that you have to have some contact lens in free interval, because most of KC patient uses contact lenses. They are not happy with the glasses, so they go for contact lenses using from years. So if they are on soft lenses, at least 1 week gap should be there. Soft toric 2 weeks, with RGP 4 weeks. If they are on scleral lenses, 5 day to 1 week gap is good enough, because cornea is well hydrated in these patients because of the good vaulting. And key consideration for keratoconus, another important factor is a stable measurement. The goal is to obtain two sets of measurement 3 to 4 weeks apart that shows no significant changes. You also have to confirm the progression because sometimes there is a mild progression in cases. So if you have any doubt, wait for surgery for a few months, repeat the pentacam, compare it, and then plan the surgery. And so coming to the choice of IOL, keratoconus have negative spherical aberration. So monofocal with positive spherical aberration is a good, or you can go for the neutral spherical aberration lenses also. Toric lenses are a good option in mild to moderate cases because it gives chances are there that patient will be glass free with toric IOL, and it gives a good spectacle corrected acuity, and mostly it covers the astigmatism nicely with toric IOL. No need for going for contact lenses post-operatively. And definitely, keratoconus should be non-progressive. Avoid multifocals in all cases of keratoconus because there are a lot of scattering. The quality of vision is very poor. So it's not a good idea to consider multifocal in KC cases. So coming to the final slide, this is so to get a good biometry in keratoconus, ensure keratoconus stability. That is the first point. So many of the time, there are some scars on the apical scar. If we find that the chances of getting good outcome with the cataract is not there, and you have to consider DAL in these cases. Better to perform graft first, remove the sutures, and then go for the cataract surgery in these cases. Use optical biometers, use AKR as I discussed previously, and again, always aim for myopia of 1 to 1.5 diopters. And again, in the end, under promise, over deliver, because that is your savior in the keratoconus cases. Thank you so much.
Thank you, Dr. Bhupesh. That was a very good talk. Dr. Deepti, would you also go with Barrett's True-K as your choice for keratoconic eyes post-cataract?
Yeah, Soumya, hi. So I think it's not one formula. Again, for us, we do multiple formulas, and I don't think we do true care for all patients. But yes, that is certainly a very good formula for keratoconus.
So what
So
formulas would you use to compare along with Barrett True-K? Because Barrett True-K is quite reliable in most cases, but what else would you like to compare? What other formulae would you like to
So
compare?
we run all of those formulas which Bhupesh showed us. We look at the variability between all of them. And yeah, one of those those specific formulas for keratoconus, I think Barrett's True-K is one of it.
Okay. Dr. Dishita,
So,
would you
but
like
it's
to
very
add?
tough to say one formula, Soumya. I think each
That's
of
true,
us,
yeah.
depending on us, so I don't want to say one,
Yeah.
but I think an averaging of 3-4 post-KC formulas.
Best to
And
compare
as
across and
Bhupesh,
look for
because some
agreement.
may take it from pentacam, some may take it. So it's nice to amalgamate at least 3-4K readings from different machines, run 3-4 formulas. And as he said, choose a lens which is most myopic there. So at least if you're erring, you're just giving him myopia, which is still okay.
Dr. Dishita, anything to add?
No, I think Dr. Bhupesh summed it up well. It's safe to say that it's easier to pick formulas in the mild and moderate cases, and the severe cases are always tricky. One of the recent articles that I was reading on IOL formula in KC clearly said that the Kane KC formula has not been doing well. So that was one of the recent updates in, I think, December 25, it was published. So that is one thing I think we should keep in mind. The Barrett's True-K, of course, has been doing very well for a long time. And I'm sure Deepti ma'am also agrees that it's truly quite reliable when compared to a lot of the other formulas.
We
and
have
one thing from
some,
as
yeah,
Bhupesh
yeah.
said, toric lenses is something we should really consider in keratoconus. When we learned that multifocals and torics are only for virgin corneas, pure clean corneas, but KC patients do very well with toric lenses. So here we are not targeting to make them glass free. Here we are targeting to make debulk the astigmatism. They have huge astigmatism, 8, 10, and you can always do, even if there's a little asymmetry, a central cone works very well with toric, but even if you have a mild asymmetry, you'll be surprised how well they do. So multifocals and EDOFs, absolutely no, but toric lens is something that you should really consider for keratoconic eyes.
I think I absolutely agree with that. I have been implanting a lot of this Ultima Smart Toric from Care Group.
Yeah.
So they
Okay.
give very high cylinders, and it's giving wonderful results in these patients.
So if there is asymmetric astigmatism, would you correct the lower part of the asymmetry? Would that be what you would target?
See, even if there's asymmetry, your formulas are anyway calculating from the center. So you do your regular K readings and all, like Bhupesh said, and whatever your IOL calculator gives, it gives. You're not looking at de-cylindrizing the entire thing. So the central K readings and from your pentacam with the true K toric is what you require. So you will be sort of debulking a large amount of cylinder from the central 3 to 3.2. And I think we are all very fortunate in India to get such beautiful customized lenses, which nowhere in the world you can get. And these are the
Absolutely.
patients you should really use them for. And earlier there was an issue if they're using contact lenses, but now there are very good scleral lenses, cornea scleral lenses. So even if they want, we can give them. That may not be an ideal scenario after toric. So that's very important. If a patient is already on IGPs or scleral lenses, don't put toric because they will want that crystal clear vision. And having a 10 cylindrical lens and again a scleral lens outside is quite not the great. But if there's someone who has not been using lenses, then toric is a good option.
Okay. So we have two questions. One is how to confirm foveal fixation in high myopes. And I will take that question. So it will again depend on what instrument we are using. If we are looking at something like Immersion, if that's the only thing that's available, then we would probably go with the longest reading that we get. But also most importantly, it should be repeatable. And a good quality scan. If it's optical, then if it is a OCT based one, then you can look for the foveal dip and to make sure that is the axis that is being measured, and then the staphyloma is pointed out as well. The next question is how to stay updated on A constants of IOLs. Do you use company constant or optimized constants? And so I personally use the company recommended A constants. Does anybody have any other way of doing this? Does anybody
So we
use
have to use
personalized A
company only,
constants?
but because sometimes they have two constant, one for the optical, other
Yes.
for the contact. So that you have to take into consideration. Yes, you have to follow company
Yeah.
norms.
Depending on what method you've used, you will need to go with that.
A
And
couple of
also,
points.
Yeah.
Sorry.
I think Dr. Bhupesh will have to stop screen share.
Oh, sorry. Raju.
Dr. Deepti and Dr. Bhupesh, coming to keratoconus, toric IOL, yeah, definitely it makes a lot of difference. I agree with you. I've placed my largest cylinder I've placed inside the keratoconic eyes 12, unaided from 636 to 612 part she is reading. She's a nurse. She's a sister in Dubai. She's very happy. I agree with you. But 2 points to consider. One, you have to see whether the cone is central or paracentral.
True.
Central cone, yes, I agree with you. Toric does wonderfully well. But inferior cones, no, they don't do so well. And second point, Dr. Deepti, you told you would go for myopic. No, I would go for hypermetropic here. Hypermetropic plus undercorrection. Why? I will tell you my theoretical reason for it. Because the least point of confusion comes on the nodal point. If you make it myopic, it comes in front of the nodal point. When the least point of confusion comes at the nodal point, the patient's vision is that much more better. What do you think about it? Strum of conoid, if you remember.
Get it. No, strongly, I would not want to make my patients hyperopic.
Yeah.
My
I would still
experience.
stick to a myopia of 1 to 1.5. But
Okay.
I think,
Yeah.
yes, it's
Okay.
what works with each
Dr.
other.
Bhupesh, you can stop screen share.
So
Dr.
I've
Naveen,
done, I
you want?
think.
Yeah, done. Now it's done. Dr. Naveen, do you
Done.
want to try sharing your last two
Yes,
slides?
I've changed my laptop. Hopefully it will
Okay.
work that now. I'm using my yes. Last two slides. Let me see if this works. Yes,
Yeah, visible.
fantastic. At last, Bangalore guys are making a comeback. Thank God. Some tips I wanted to share when I am doing the immersion method. There is a mark each and every time you do a scan. No, please make sure the probe there is a circular mark on the shell. The probe must meet that mark. Each and every time you do that A scan with the immersion, you please check the probe is at that level. I'll demonstrate in the video when I'm doing that. Next is the probe tip should be totally submerged in the water before you go to the scan, or else you'll get erroneous readings. Make sure the machine is set to immersion mode, which I've already mentioned. The correct velocity settings should be chosen as discussed earlier. Harder cataracts and high myopia usually do in dense cataract mode settings. When the beam is properly aligned with in the center of the macula, all 5 spikes you will get it beautifully well. Oh, have I not enlarged it? Sorry. Yeah. So what are the advantages of biometry? Immersion biometry, reproducibility is beautiful if you get it right. And the accuracy, whoever does it, it doesn't matter. Applanation does matter who does it. You need to have certain amount of theory knowledge and practical knowledge when you're doing applanation. Immersion, not so much. If the patient fixates well, you'll get pretty much good reading. You avoid corneal compression with the biometry, with immersion biometry. Possibly to identify the anterior corneal spike very clearly in immersion than compared to the applanation. In posterior staphylomas cases, as the velocity is much more better in the liquid, you get the macular center. To identify it, it's much more easier than the applanation one. And one more tip is, please do your biometry as far as possible, undilated pupil than a dilated pupil, so that you hit the macular fovea always. It allows measurement of the correct axial length even in the oil-filled eyes, since the retroorbital fat is very well seen in the immersion. My last slide, I'll just show how I do in my clinic. As you can see, I always check the mark. Instead of the tube, you use the syringe with a long needle. If you are well versed with it, it doesn't take much. 10-30 seconds. This is an unedited video. That's it. You're done. So as you can see, it just takes 30 seconds. If you're well versed with it, if you're IOPD is ergonomically managed, it takes very short time, 30 seconds, and you can see you get a very well spike. This is how I do my applanation. You have to hold the wire. Don't ever hold the probe. And always, I also prefer to do in the undilated and in the supine position. Don't press the eyelid. See the spikes, you get beautiful spikes. You can see here. Yes, that's it. Thank you.
Dr. Naveen, do you have any experience with this MMD scan? They have a small sleeve instead of this Prager shell. A small sleeve
Yes, sir,
is there which you can attach to the tip and take the immersion. Any experience with that?
Yes, sir. My friend has it in Ilkal. Dr. Shivaji has it. It gives almost the same readings as this one, sir. But with very big eyes, I doubt it. I don't have much experience with it myself. My friends have used it. They say it is quite good, a bit more comfortable than this 20 mm shells.
Yeah, I'm using that one actually. I have the MMD scan.
What is your experience, sir?
It's quite good, but of course I use it only in cases where I cannot get the optical biometry. Results are quite good.
Okay.
Yeah.
Dr. Naveen, you can
Over
stop
to you.
screen share.
Yes, I'll stop. I'm stopping.
So I'd like to thank all our panelists and speakers for making time and sharing their little nuggets today. And I'd also like to thank all our office bearers, Dr. Shivram KV, Dr. Anand Bandari, Dr. Ravindra Banakar, Dr. Krishna Prasad, who has been guiding us throughout this program. Also our secretary, Dr. Sunil, and scientific committee chairman, Dr. Shivyogi, Dr. Ilan Kumar, Dr. Sharath, and Dr. Kavitavi. A big thanks to all our zonal representatives and scientific committee members for making sure today went very smoothly. And also a big thanks to our supporters for for putting everything together, microlabs, and also for the artwork. And if any of our speakers want to add something else, you're most welcome. Thanks to Mr. Navneet as well, who's been very involved right from the beginning, and Microlab's vision for supporting us through all our CMEs, even including the last one.
Thank you, ma'am. It's a pleasure. We are always there for helping all the scientific events, ma'am. Yes, thank you.
I'd also like to thank ICE Pharma for getting the flyers ready, although they are not logged in here. A big thanks to you as well. Does anybody have any other thought to share before we log out?
No, thank you. It was a wonderful session. Thank you, Dr. Soumya. Very well organized. Thank you.
Thank you. And thanks to all our viewers for logging in and for participating.
Thank you. Bye. Good night.
Thank you.
Good night.